Hi, welcome back to JAMA Network Open Live. I'm Seth Truger, Digital Media Editor at JAMA Network Open.
And I'm Mike Berkowitz. I'm the Electronic Editor for JAMA and the JAMA Network, back in my seat next to Seth.
Great, thanks for coming back, Mike.
Sure.
First up, just briefly wanted to mention that today is National Physician Suicide Awareness Day. Unfortunately, physician suicide is still a pretty big problem. It's something that really does affect a lot of doctors, families, people, a lot of our colleagues, and it's something that we should certainly at least talk about a lot. CORD, the Council of Emergency Medicine Residence Directors, as well as some other groups, are sponsoring National Physician Suicide Awareness Day. There's information on their website. We also found the JAMA Network has done a number of papers on physician suicide over the years. There was a recent one, or a couple years ago, in JAMA Psychiatry among physician trainees, some others back a few years ago. What was really enlightening and a bit depressing to me was looking back just how long this has been recognized as a problem and how little progress we're making. We found papers in JAMA back from the 70s or early 73. So unfortunately, still a lot of work to do.
Right. I'm not sure of the epi data, but the sense is that it's becoming more common. That could be because it's easier for us to hear more about it. Certainly, we all know about the pressures that are coming to bear on health systems and practitioners in those systems. So if you need help, call for help. This CORDM website, we know the web address, may have some resources. And keep an eye out and support your colleagues. And talk, by all means, if you're feeling the stress.
Absolutely. Great, thanks. So on that note, moving on to our first paper, the Association of Emergency Clinicians Assessment of Mortality Risk with Actual 1-Month Mortality Among Older Adults Admitted to the Hospital by Dr. Kei Uichi and colleagues. And we've got Dr. Uichi with us. Welcome.
Thank you for having me.
Great, thanks. I'm glad you could join us. So tell us a little bit about yourself and what you did here in the study.
Great. Well, I'm an emergency physician by training, and that's what I clinically do here at Brigham and Women's in Boston. And as you know, we meet a lot of patients with serious life-limiting illness in the emergency department. A lot of these people don't receive palliative care when we know that palliative care early could really lead to improved quality of care and survival. So we wanted a quick way to find out whether some patients can be identified to receive palliative care. So that's what we did in this study. Surprise question, termed "Would you be surprised if your patient died in the next 1 month or 12 months?" has been studied in other clinical settings. And this time we wanted to study that in the emergency department in a much larger cohort. So we followed 10,737 patients who are 65 and older in emergency department who are getting admitted to the hospital and academic medical center. And we followed them for 1 month to 12 months and see if the physicians and clinicians' input into that surprise question is related to the actual mortality.
Yeah, and what I really liked about this project was that it was just a very simple single question.
Yes.
We've got a ton of screens. We've got depression screens. We have fragility screens. We have delirium screens that our patients get all the time. Our nurses are spending a lot of time in doing a lot of these or recognizing patients, and this is just so simple. And also the kind of choke point that you're doing it at the moment of putting in the admission order, which is just an intuitive thing to think about which patients are pretty sick and might be at risk of dying in the next month.
Yes.
Yeah.
Yeah. So I admit that it's really kind of an elegant way, partly because it puts the kind of the predictive prognostic capacity back on the clinician instead of kind of getting all tangled up in prediction scores and so on. One thing that the paper wasn't so clear on was the diagnoses of patients. You have symptoms, but you don't have diagnoses. And I noticed that one risk factor for mortality, which is pretty intuitive, is that these patients come into the ED from who were transferred from nursing homes. So that raises the possibility that these ED physicians were evaluating patients who were old and quite ill. You capture that in the comorbidity, in the Charlson Comorbidity Index, which you adjusted for. But I guess I'm wondering whether these were patients that almost any clinician would say they're not doing so well, they're near the end of life, they have end-stage cancer, they have end-stage dementia. I guess an end-stage cancer wouldn't be in a nursing home, but whether this is kind of intuitive and you're just not kind of reporting out the clinically intuitive variables that would lead, that would give more information about these predictions.
Mm-hmm. Yes, so I do agree that surprise questions answers are sort of an overall assessment of clinician, which may include the comorbidities or like transfers from nursing homes. And that our hope is that surprise question would encompass all of that by clinicians' sort of overall intuition to answer that question. And yes, we did try to control for other variables like the admission source, from where the patients came from and things like that. And we still found that surprise question is independently associated with 1 month mortality.
Mm-hmm.
I really like that point about it puts the judgment back into the clinician, because as you saw, the sensitivity of this test is not very high. But it begs the question, if a clinician answers, no, I wouldn't be surprised, what should we be doing next? And that's why this, I think, is an important finding.
Mm-hmm.
And the policy implication, which I think you mentioned, is that perhaps, and I don't want to extrapolate or put words in your mouth, that perhaps we could consider not admitting this patient in hospital, putting them through an expensive and invasive hospitalization, but instead call palliative care services or find alternative ways to manage their symptoms. Is that fair?
I think that non-hospitalization is not what I think the goal of palliative care is, as you probably know. Mainly trying to find out what's the most right care for that patient at that time, which may include hospitalization to control their symptoms or improve their caregiver burden. And that the policy implication, I think, is that this is the time to decide what is the right actual level of care for patient, which may include home hospice, but which may include admission to the hospital to control their symptoms.
Yeah, and ultimately down the road, being able to initiate more dispositions that are alternatives to hospitalization, like home hospice from the ED,
yes,
easily and without a big burden, certainly does make a lot of sense. We don't like. I don't think I've ever worked in a place where I've had easy access to palliative or hospice care from the ED. I think
yes.
I've had probably 3 times as many rheumatology visits in the ED as I have palliative care consults. Just because the way hospital operations work, the scheduling, timing, resources, etc., and it's tough. I was one of the things as a very little bit of a biostats nerd. I think one of the things that's interesting to me is how the different test characteristics played out, and how the sensitivity is so poor. We're only identifying 1 out of every 5 patients who actually did die in the next month. But the positive predictive value is pretty good. The negative predictive value are pretty good, and it's just the interplay between those is pretty interesting. I don't know. It's just this.
And I think those
for med student intern biostats rounds.
And all those numbers were actually all over the place on prior studies because the sample size was so small. So I think that it sheds a little bit of light on not to sort of over rely on this test alone. But I do agree that I think getting palliative care consult or referral to hospice from emergency department is still really hard. But I really think that the role of the emergency department is starting to change, not only to provide acute care like gunshot wound care that we do very well, but also to figure out what is most appropriate for the right patients at the right time.
And usually, I'm going to ask you guys as ED docs, usually that involves family conversations. How easy are those to have in an ED setting for these kinds of patients?
I'll let you take that one.
Yeah.
You can start.
So, yes, I think most emergency clinicians working right now would say that, it's really variable. It really depends on the fact that caregiver or family is there. I think that's really variable. Sometimes they're there and sometimes they're not. But I think we have to take what we have as an opportunity to involve them as much as possible, depending on how much the patients would want. And I'm exactly working on that right now in other studies that are not relevant to this talk.
Okay, great.
Great. Well, that's great.
Well, we would look forward to seeing that, perhaps.
Yeah, absolutely. Great. Well, really great study.
Yeah.
Thank you for joining us today. Thank you for submitting to JAMA Network Open, and keep up the good work.
Thank you so much for joining.
Pleasure chatting. Thanks so much. Take care.
Bye-bye.
Oh, great. All right. So moving on.
Yeah,
to
moving
our
on.
Table of contents rundown. We've got a whole bunch of stuff today. First up, there is the JAMA Network Open is issued a call for papers for climate change and health papers.
Yes.
Basically, any sort of research on what the potential effects of climate change could be to our patients, our health systems, et cetera.
Right, with a particular interest in examining how climate change affects people most susceptible to environmental degradation. People at extremes of age, chronic illness, performing physical work in the heat, and those with homelessness, poverty, or food insecurity.
Yeah, and not surprisingly, vulnerable patients are going to be vulnerable.
Right, and it's the vulnerable patients who are most at risk for these environmental changes.
Right. And I think it's this is one of the situations where it's kind of easy to have a simple gut reaction of, wait, climate change and health, isn't that multiple steps away? And the editors do a good job of talking about how there's both direct and indirect effects, how climate change will affect other organisms, the food supply, the degradation of natural environment, air pollution we know has all sorts of acute and chronic impacts on things like asthma, allergy, cardiovascular disease, and as you mentioned, things like food security, malnutrition, water access, immigration, changing populations, all sorts of stuff. So there's lots of reasons why this is relevant for our patients now and going forward.
Right, and one of the major newspapers, I think it was the Times, showed a map of areas of the world that have already experienced the 2 centigrade increase in temperature that's supposed to be the threshold for catastrophic change globally. So apparently it's already happening in accelerated fashion in these kind of isolated microclimates. So the exposure's already there.
Great, more good news.
Yeah, more right.
Yeah.
Right.
All right.
What's next?
Shifting gears a bit. So this next paper, they looked at U.S. FDA approvals of drugs and devices based on non-randomized controlled trials. So they did a systematic review and meta-analysis. They looked at almost 700 different studies, but ended up drilling down to 36 drugs and 32 devices that were approved for breakthrough therapy from 2012 through 2017. And basically just looked at the ones where the target was the ones where there weren't RCTs, but they still got approval, and looked at some of the different properties.
Right, and the context for this is that RCTs are really expensive and sometimes incredibly long to conduct, so that there's this evolving standard that so-called dramatic effects, really large relative effects in observational studies, may be sufficient to push forward a drug for approval, on the premise or on the presumption that if it's a really large effect, that any amount of allocation bias or confounding probably wouldn't eliminate a benefit of the drug that's observed in an observational design.
Right, exactly. If it's so good that it's so good to be true, it's probably still pretty good.
Exactly, right.
Yeah.
And we have somebody joining us?
Yeah, we've got a Dr. Jeremy Gu who's joining us. Welcome.
Welcome, thanks. Okay, anyways, continue.
Yeah, some of the things that came out of this, some of the interesting stuff. So 1 in 4 of these studies, the FDA did ask for further testing. They did ask for an RCT. They looked at it a few different ways, like using thresholds of a relative risk of 5 or 10 in these observational trials, and there wasn't any specific threshold that they could find where the FDA consistently didn't request an RCT. So it's big dramatic magnitudes, but not a specific level. And one of the other things, and this is to be cynical again, explicit numbers for both numerator and denominator for control arms were only available for 10 studies, which is, I'd say, concerning.
Right. One of the things one of my impressions of this is this really describes how the FDA behaves, the kind of the evidence base that they use to push drugs forward or to request further RCTs. So it's describing how the regulatory agency makes its decisions. It's not talking about whether so-called dramatic effects in observational studies are actually sufficient for the public's health in these kind of regulatory decisions. And I kind of thought a next natural step would be a messy study, would be to somehow compare safety of drugs approved based on these observational designs versus those that were then put through the RCT process and then approved. I don't know if there's adequate numbers to make those comparisons, but that would be kind of a next step to figure out whether the FDA is kind of, and I use this term loosely, shortchanging or accelerating too quickly by granting approval based on these designs.
Yeah, because there's been a big trade-off in the last, I'd say, decade or so, where there's been a big push for things like rare diseases, breakthrough therapies, et cetera, things where, as you said, it's hard to do good, high-quality RCTs for a lot of reasons, especially in rare diseases where there aren't big sample sizes to recruit, and where there's not necessarily a lot of money there, and there's a lot of, I'd say, some political push towards accelerating approval because there's no other options or
Right.
or nothing else to do. So it's interesting.
And if this isn't interesting enough to you as a viewer, the author byline here is the Ocean's 11 of clinical research. It has Paul Glasgow, John Ioannidis, Ian Chambers, and Ben Dielbegovich, all of whom are kind of marquee names in clinical epidemiology, and other co-authors who I'm sure are outstanding. I'm just not familiar with their names. But this is really like the highest talent in our industry in terms of putting this information together. So we thank you for sending your work to JAMA Network Open.
Yeah, and I'm just impressed you can pronounce all this.
Right.
All right, moving on. Next up, cost minimization analysis of same-day long-acting reversible contraception for adolescents. Basically, standard, especially I believe standard in Medicaid is not to cover both the visit where an adolescent decides to get long-acting reversible contraception like an IUD, and you have to come back for another visit to get it placed. There's all sorts of billing reasons, a lot of clunky stuff. It ends up being basically administrative and logistical hassles, and not surprisingly, a lot of people don't return, don't have contraception, end up getting pregnant, etc. And there's also, again, some politically motivated reasons why some people want barriers for vulnerable patients to not get birth control access, unfortunately. So these authors did an economic analysis and found it basically saved about $2,000 per patient over the year. That's a lot of money. It's basically saving healthcare dollars, saving public taxpayer money, getting people better access to care, avoiding more, premature unintended pregnancies, et cetera. From I'm not an expert in this area, but from what I know, that whether or not adolescents have contraception doesn't do much to change whether or not they engage in pregnancy-related behaviors.
Well, that's the cultural fear in our society, right?
Right, but facts don't care about our fears.
And just to be clear, I mean, this is a cost simulation.
Right.
It's not observation, but it's totally intuitive. Why not give our patients the services they come to the health system for when they're there, instead of making them kind of visit twice, which you're always going to lose people along the way.
Right, and especially when you're looking at a Medicaid population where there's vulnerability towards access to taking off time from work or school, transportation requirements, et cetera, to get to the doctor.
Right.
And so having to do it again is important. Oh, go ahead.
Just LARC is not only IUDs, but they're hormonal implants. I'm forgetting the names in the moment because I'm blanking and my brain is aging, but they're kind of small little rods that provide months and months of hormonal contraception.
Yep, absolutely. So interesting stuff. Also, just methodologically, the way there's the box in the study where they talk about the assumptions they put into their model, and it's just one of those things where you could have a field day with a small group of med students talking about the pros and cons of the different assumptions, and this stuff's just fascinating to me, and I know I'm a nerd. So moving on, we are returning to a topic we talked about a couple weeks ago: MRI imaging guided confirmatory biopsy for initiating active surveillance of prostate cancer. So again, instead of just doing big, I forget what it's called. It's non-targeted.
A transrectal ultrasound guided biopsy.
Yeah, where they do systematic biopsy of everywhere in the prostate to do MRI guided biopsy. So they looked at 322 patients who were getting active surveillance for low-risk prostate cancer, who had a Gleason grade 2 or lower. They used, I love this term, MRI guidance with an MRI ultrasound fusion device, which is just.
Is that like fusion jazz or fusion?
I think it's like the
Asian cuisine. Yeah. No, okay.
Yeah. Well, kind of. Yeah. And they tracked the patients and found and did the biopsies and basically found that it worked pretty well at making sure they weren't, basically do less invasive care to still appropriately identify the worsening cancers.
Right, and to be clear, I think the difference here is that these are patients who were enrolled in a surveillance program. So I think the other studies that we discussed here and that we published elsewhere in the JAMA network are patients who are undergoing biopsy for diagnosis and then the role of MRI for that. So these are patients who have been deemed to have low risk or indolent cancers who are in a surveillance program. An MRI improves the ability, we think, to detect upgrading or upstaging of their cancer in that surveillance period.
Yep, absolutely. And I'm not a urologist. I'm not an oncologist.
You're not.
I'm not a screenologist, methodologist either. And I do know that there is a much bigger question about the use of MRI for prostates that I do not know enough to have an opinion on, but these two small pieces of the puzzle are certainly interesting.
Okay.
All right, moving on. Genetic approach to the association between PCSK9 and sepsis. So PCSK9 is a gene that's really hot right now for identifying cholesterol in people at higher risk of coronary artery disease. It's a target for newer anti-cholesterol drugs for managing CAD, and there's apparently been some preliminary evidence for as a target in sepsis therapy. Basically, and I'm going to do a lot of hand-waving physiology now, that there's lipopolysaccharides and gram-negative bacilli, and it activates cytokines and all sorts of other stuff. So what they did is they looked at a huge group of patients, 11,000 patients who were admitted to the hospital between 1993 and 2017, which is a big time frame, and who had genome-wide typing that they could do analysis to see if they had the
So they had blood samples that they could do contemporary sequencing on.
Exactly. Something like that. Yeah, something like that. And basically, 11,000 were admitted. 3,400 of them ended up getting sepsis, and 400 of them ended up dying. And unfortunately, the risk of sepsis was not associated with anything related to do with the PCSK9 gene, nothing to do with the functional variants, nothing to do with the genetic risk score, or nothing to do with the genetic estimation of PCSK9 expression levels.
Right. So this sounds convoluted.
Yes.
And it is pathophysiologically, but the PCSK9 gene leads to the LDL receptor being destroyed, so that if you inhibit PCSK9 with drugs, and when the receptor is destroyed, then LDL circulates, and that leads to elevated LDLs in atherosclerotic disease. That's why the drugs were developed to inhibit the gene so that the receptor can suck up the LDL. And apparently lipopolysaccharide from the gram-negatives attaches to LDL. So it's a similar thing. The lipopolysaccharide is circulating if PCSK9 is active. So they're looking at kind of loss of function variants in particular. What wasn't clear to me from this is they kind of talked about how many patients had the genetic testing and how many patients had sepsis, but I didn't know that intersectional cell of how many patients with sepsis actually had loss of function variants and how many people with loss of function variants didn't have sepsis. So it was a completely negative study, but methodologically I wasn't sure how to interpret it. It was a little black box to me.
Yeah, and it's interesting because this doesn't mean that this won't be a target for sepsis therapies. It just means that this doesn't seem to be a way to risk stratify your patients with infection who haven't developed sepsis to figure out if they will go on to develop sepsis.
And this question doesn't come out of nowhere. It comes out of suggestive evidence from animal studies that these loss of function variants may be related to sepsis in the, I guess, a rodent model, a mouse model. And of course, if that's the case, then there could be interventions that would be preventive and protective against sepsis and its complications. We have a new viewer.
New viewer. Welcome, David Miller. We are shifting gears entirely to something, again, outside both of our wheelhouses, which is always fun. So quantitative eye gaze and movement differences in visuomotor adaptations to, I lost the title, but
to what? In patients with prostheses,
patients with upper extremity prostheses. So this was a small study, eight patients with upper arm prosthetics of various types of injuries. They were all from acquired injuries and not congenital, and compared them to 16 participants with routine arm function, and basically had them do two tasks. One of them was pick up a cup of beads that simulated liquid and lift it up and over, basically like a table tennis tent, I think. And the other one was to move basically a spaghetti box, which it was interesting. Although the pasta box has some inherent instability owing to its shifting contents, the task was assumed to be less risky because dropping or compressing the box would not result in spillage of contents. Yeah.
I'm getting hungry.
Yeah, it's good stuff. So it's really interesting, and basically they did all sorts of movement analyses. They videotaped these from a few different angles and watched how the people who were prosthesis users and people who had normal arm function, what kind of angles they used, how they compensated. They did eye tracking, and basically try to do some of the mechanics of how people move, and basically there were different things like how they compensated, and basically there were very small differences in how they actually and how successful they were with the tasks, but bigger differences in things like where they were looking when they were doing the tasks. So it only took about 13 seconds longer for the prosthesis users to do the first task, and not spill the beads as they're moving the cup, but they looked at the cup more while they were doing it. And same thing with the native arm users, were able to, basically not really look at the pasta box where they were moving it.
you've lost me a little. What's the research question?
Basically, I think this gets down to ultimately down the line how you design prosthetics that people can control more. I think it's things like, do you need to be doing eye tracking? What kind of angles do you use? Do you compensate with your trunk versus moving your shoulder? I don't know. It's cool biomechanics stuff that's well on my wheelhouse, and I don't really know.
But across the street, right? Because
Yeah.
the Ability Lab is right there.
Yep, absolutely.
Okay.
Yeah,
Anyways.
yeah. So it's just cool and interesting biomechanics.
Yeah. And no videos, right?
No, I don't have any videos.
Okay.
That's too bad.
But we'll boil the water to
Yeah, I cook a lot of pasta at home, so
Yeah,
we can get something.
abbondanza.
Yeah.
Okay.
All right. Next up, association of the PEPFAR funding with prevention of mother-to-child transmission of HIV in Kenya. So in the early 2000s, the Bush administration started some funding for basically supporting and reducing HIV burden in Africa. This is an analysis of some of that. Basically, there was about $250 million invested in Africa from 2004 to 2014. At the same time, there's a decrease in child mortality by half. Obviously, that's not, quid pro quo, and that doesn't mean that
Meaning causal.
Right.
Yes.
But basically, doing some more fancy analysis and estimates of what the direct effects could have been, et cetera. Basically, per person, if you increased spending by about a third of $1, so 33 cents,
Yes.
which brings the spending from the 75th percentile to the 25th percentile per individual, which is not a lot of money, you reduce infant mortality by about 16%, is their estimate.
Okay, so you get a huge...
Yeah, big bang for the buck in trying to prevent HIV transmission and morbidity in Africa.
So this too is a cost simulation model, or is this observed data?
I think it's observed data and then trying to analyze what the actual benefits were of the dollars that were spent.
Okay. Yeah, but so that's a happy paper.
Yeah, it's a good paper. Yeah,
okay,
it's good stuff. Last up, a research letter on the association of grit scores with treatment adherence and biomarkers in patients with type 2 diabetes. They did in-person surveys on 442 patients in Mexico with type 2 diabetes. They used this validated tool, 8 items on the short grit scale. So grit being the perseverance of effort and consistency of interest, and basically how much people are resilient and can work hard.
Like whether viewers have watched this far in the broadcast.
Right, exactly.
Right?
Yeah. Okay. And basically overall, there's a 50 to 75% spread in treatment adherence, and the grit score correlates with about 6 to 12% of that difference, or 6 to 12 percentage points. So basically, patients who have more grit are able to, have that stick-to-itiveness to take care of their diabetes better.
Right, and so you've called yourself a stats nerd, and I'll just call out one really trivial, wonky thing here, which is that change in adherence is per standard deviation on the scale, and they never describe the distribution of scores and the standard deviation unless I missed it.
Yeah.
And standard deviations are often kind of miscalculated when the distribution is non-normal, and so sometimes it's kind of wonky, and I just kind of wanted all that information to know what to make of this.
Yeah, I think it's tough as a research letter. There's only so much space to put in the information.
Right.
And perfect's the enemy of good.
Yep.
And grit may be the enemy of diabetes.
And the acronym is GRITS, or GRITS. It's really GRIT-S, but it made me hungry again for grits.
Are they magic grits?
They are not.
Okay, great. Well, thank you for joining us. Of course, you can read these papers and more at JAMAnetworkopen.com. Everything is free and open access. We should be back next Tuesday at 3 p.m. Central Time again. Follow us on all the usual social channels, Twitter, Facebook, LinkedIn, YouTube, Pinterest at JAMA Network Open or the JAMA Network.
Listen to our podcast on any audio platform that you listen to your podcasts on. I may or may not be back next week. You have to tune in to find out. Angel Desai, I think, may be here, whether I'm not here or not. And in JAMA.com, we announced the Peer Review Congress. So if you're interested in clinical research, there's a quadrennial, every 4-year meeting that talks about improving what we do at medical journals, including the process of peer review, the elimination of bias in science, the distribution of science, and that'll be held in Chicago in September of 2021. So go to JAMA.com and our new online first releases just to understand what the Peer Review Congress is, or go to peerreviewcongress.org for more information about the meeting. It's a call for research. And in about a year, we'll call for abstracts, and it's really an interesting meeting.
Yeah, absolutely. In about 2 years, you can email me or reach out on Twitter, and we'll set up some time to get some coffee.
Okay, great.
All right.
So thanks for joining us. Take care. See you next time.
Great. Thank you.